maybe
No, they were all impressed with the
I was not
webinar.
feeling well. I was not feeling well. I was very suboptimal. I don't think I did justice to it. I see, got it in the 80s, until the 80s and maybe beginning of 90s, through dental procedures. Most of them were women who got cesarean sections or gynecologic.
They cannot hear you, I believe.
Hepatitis C. Okay. And hepatitis C is, most of us got it until the beginning of 90s. In the Western world, the virus became known in the 80s, and latest by the late 80s, it had stopped being transmitted. But in India, it continued transmitting until the early or mid 90s as well, because the test was not available across all the labs and hospitals. So it is always transmitted either via a surgery like appendicectomy, kidney stones. Women got it for cesarean sections, hysterectomies, tubal ligations, all sorts of small procedures, accidents sometimes, blood transfusions. And it normally takes about 20 to 25 years for hepatitis C to develop into cirrhosis. And approximately one out of every 4 or 5 patients having hepatitis C will end up with cirrhosis and end-stage liver disease, which may need a transplant. There are certain associations between hepatitis C and liver cancer. So a lot of patients with hepatitis C get liver cancer as well, although liver cancer is more common in patients with hepatitis B. But hepatitis C also ends up, like I said, 20% or 25% with cirrhosis, and those who end up with cirrhosis may have a liver cancer as well. And these patients would need a transplant. Now, the incidence of hepatitis C in the general Indian population, like out of everybody, if you take any 100 normal people walking on the streets, approximately 2 of them will have hepatitis C, whether they know or not. So that's a very high incidence. Out of every 102 people is a very high incidence. Similarly, hepatitis B is about 4 on an average in India. Certain parts of our country, like in the northeast and certain areas, it is as high as 8.5 per 100. Normal population I'm talking about. I'm not talking about any selected patient population in hospitals. This is average population surveys. So between hepatitis B and hepatitis C, approximately 6 out of every 100 Indian normal citizens are affected. And out of this 6, about 20%, so say 1.25, almost 1.2, out of every 100 has hepatitis B and C related cirrhosis of the liver, all the way. And additionally, hepatitis B can cause liver cancer even if the patient does not have cirrhosis. So these people, hepatitis B with liver cancer or hepatitis B with cirrhosis and hepatitis C with cirrhosis, with or without cancer, they need serious forms of liver surgery, most of them liver transplant. So this is the disease burden. For precautions, now what you need to do is, most of the people here are unfortunately aware of the liver disease and has come to know most of it, by the time the disease has advanced and presented itself clinically. But if people were to undergo a preventive health check, like we have master health check and various other forms. So preventive health check, which includes hepatitis B and C testing, is the only way to really prevent it, or rather prevent the clinical form of it. To detect the hepatitis C when the liver is not cirrhotic offers a reasonable chance of control of the virus and prevention of hepatitis C related cirrhosis. But if you came to know about the disease only when the disease presented itself clinically, either because of ascites or leg swellings or vomiting of blood, encephalopathy, bleeding from everywhere, bleeding from the gums, all those things, then that is not the time when you can treat hepatitis C. It's already too late for it to be treated, and even if you attempt, it won't be tolerated. So the best thing to do is go for the treatment of end-stage liver disease, and with the new liver, be cautious. And keep an eye on the viral count, keep an eye on, most importantly, the condition of the liver, how it is affected by the hepatitis C. And at the first sign of serious affection of the liver by the hepatitis C, one should start treatment, at which point it should be better tolerated. It will be better tolerated at that point. So these are several of the reasons why we have this foundation to let the general people know, to communicate with them as to how can they prevent. If it is picked up at an early stage, what can be done, what cannot be done, where to get it done, depending upon where the query may be coming from. We also want people, all of us here, to be able to interact among each other through blogs and through a web community, so that people may get help. What the problems that we face are known only to us. A general population like a Facebook crowd will not be able to help. So we need a web community which is comprising mainly of us. Then that would be a much more focused discussion, much more useful feedbacks and informations about pre-transplant and post-transplant. Like attending a meeting like this is much more than what any lecture can convince a pre-transplant patient.
So sir, what precautions after surgery we have?
So after surgery related to hepatitis C or for liver?
Hepatitis C.
So hepatitis C, the only thing you have to do is you do a protocol biopsy. There is a lot of precautions that we have to take when we treat patients with hepatitis C. The steroid tapering after the transplant, which is normally done very early, is done a little more cautiously and a little slowly in patients with hepatitis C, because the last thing you want is them to have a rejection. The rejection, which has to be treated with a large dose of steroid, is probably the most harmful thing for hepatitis C. So in order to avoid that, we kind of be a little more optimized in immunosuppression with patients with hepatitis C. We try our best not to give them bolus of large doses of steroids. We try not to give them what is called antibodies for treatment. And these things are most commonly needed in patients who develop bad kidney disease after the transplant, which prevents us from giving some of the essential drugs like tacrolimus and cyclosporin, which are very toxic to the kidneys, cannot be given if the kidneys take a hit. And so you need to slow their start or give induction antibodies, and that is what leads to early recurrence of hepatitis C. So patients with hepatitis C need to be optimized in terms of the timing as well as the health at the time of transplant. Post-transplant, we need to be more careful with the immunosuppressant doses, levels, and try very hard to prevent a rejection. Even if there is a rejection, we try not to use boluses of steroids, try to treat them with just increasing doses of other immunosuppressants, but not steroids and antibodies. But at the same time, we would normally do a biopsy on the table after the reperfusion, which sometimes is not possible, but most of the time, whenever it is possible, it is done. And then there is a schedule, like 6 weeks, 12 weeks, 6 months, and every 6 months until the end of 3 years, that we would do a biopsy, even if there is no other evidence of rejection on the liver enzymes or bilirubin. And as soon as it is realized that the balance of hepatitis C and the liver cell is disturbed, where the hepatitis C virus is starting to damage the liver, and there is a scoring system for the inflammatory index, hepatitis activity index it is called. So when the activity index crosses 2 out of 6, or when the fibrosis index crosses 2 out of 6, or even touches 2 out of 6, there is a point in time we start treatment. This is not when there is any cirrhosis or fibrosis developing. This is just the first sign of genuine affection of the liver. So at that point in time, you start treatment and prevent the disease from progressing to a point where intervention may be needed or a retransplant may be needed. So this is the precaution that as the medical team has to take. Now, you being a surgeon yourself, you can help yourself, but for all others who are not from the medical background, the transplant team has to take care of that, and that is why we have our Shiba and our team of post-transplant coordinators who keep an eye on their labs, and we monitor the immunosuppression. And if there is any indication that the enzymes are going high, then we try to investigate whether it is because of rejection or hepatitis C. After ruling out rejection, if the hepatitis C is suspected, we biopsy and we take it forward. But even if there is no such sign, we would do a protocol biopsy at this time interval that I said. Other than that, you don't need to take care of anything. General precautions which are mandatory for everybody have to be taken by patients with hepatitis C as well.
Even in case of cirrhosis.
So hepatitis B or hepatitis C or any other thing, the pathway is through cirrhosis. So hepatitis C does not bother you unless it leads to cirrhosis. Suppose I have hepatitis C but I don't have cirrhosis, then I don't need to worry about hepatitis C. So the way in which hepatitis C hurts the liver is via cirrhosis only.
No, and when does this cirrhosis become cancerous?
So cancer develops in these livers which have cirrhosis. Cirrhosis does not become cancerous. Cancer complicates a liver which has developed cirrhosis because of hepatitis C in this case, or other causes like hepatitis B, autoimmune hepatitis, primary biliary cirrhosis, sclerosing cholangitis, hemochromatosis, alpha-1 antitrypsin deficiency related cirrhosis. Lot of causes of
So
cirrhosis.
in layman's talk, doctor, in layman's language.
Yeah, so cirrhosis is the final stage which is arrived at by many diseases. Hepatitis B is one disease, hepatitis C is another disease. All these other names that I said, no, they are names of the diseases. But ultimately, what do they do to the liver? They all cause cirrhosis. And why do you have a problem? Because of cirrhosis. Okay, you don't have a problem because of hepatitis B or hepatitis C. Most people don't even know that they have it.
Sir, after surgery of hepatitis C,
Ah.
the new drug which has come to USA,
Yeah.
he was telling that
Yeah.
it has come in Facebook.
Yeah.
That is required to take or
So, hepatitis C can be controlled by our traditional interferon and ribavirin as well. The response rates are much better after the transplant. In fact, we have had 3 patients who have had a clinically significant recurrence within the first year after cirrhosis. And they all have been treated successfully and their diseases are controlled and they are now off interferon and ribavirin as well. So, as long as you can give adequate doses and the patient can tolerate medically the combined treatment of hepatitis C with interferon as well as ribavirin, I have not seen any patient lose control over the disease. Okay. But interferon still has these side effects of cytokine release related, where you have this body ache, fever, feeling sick, and generally unwell, depression, fevers. So those can be, and ribavirin leads to low platelet counts, low hemoglobin. So those things can be prevented by these new drugs, and these new drugs are all oral. So you don't have to give injectable like pegylated interferon is an injection once every week. So that does not, you don't need to come for an injection. You can just take pills and take care of
it may or may not be required.
So now again, this is not yet approved for market use. It is only in the clinical trial phase 3. So a lot of drugs have a lot of promise while in clinical trial stage, but ultimately when all the data is collated, then only the real picture will emerge. Now so far everything looks very positive. So we all have a reason to hope that this time we will have the right treatment for hepatitis C. But that remains to be seen and proven for that matter. Because if you think about it, hepatitis B had a very similar story. About 25 years ago, it was considered useless to do a transplant for hepatitis B because the disease could not be controlled after the transplant. But then hepatitis B immunoglobulin was discovered, which basically controlled the virus and the disease very efficiently in the initial part. And then newer beautiful drugs like tenofovir, entecavir, these drugs, they have been very efficient in controlling the virus in the native or even the mutant forms. So just as improvement in medical therapy has led to such an absolute control on the virus, so the transplants have become more feasible, successful. There is no reason to even think about it. Similar things were tried for hepatitis C, and there was a thing called hepatitis C immunoglobulin as well, but it was not having a similarly effective outcome with hepatitis C.
So the answer is immediately after the transplant, there is no urgency for treating the virus.
Correct. So the virus lives in harmony with the liver cell. It has been living right now in most of the people. So they need to be treated only when there is an imbalance. The relationship is between the host and the guest is disturbed. Then the host fights with the guest and tries to kill the host. So then that guest has to be chucked out.
For a normal person to rule out this, is there any regular checkup which has to be carried out for this finding of this hepatitis B? Is there any regular checkup for avoiding this or to find out the initial stage?
So for hepatitis B now, the kids are immunized initially. So there is not a problem. Now all of us, we have not been immunized. So all of us who have not been immunized, we try to reach out to corporates, we try to reach out to pediatrics this there is a hepatitis World Hepatitis Day, on which free screening camps and immunization camps are done. So various